Our next speaker is Professor Michael HURD. Michael is the Principal Senior Researcher and Director of the Rand Center for Study of Aging. Michael has served on many important committees, such as the Social Security Advisory Council, World Bank Old Age Security Study Council, National Research Council. He's a consultant to the English Longitudinal Study of Aging and the Survey of Health, Aging and Retirement in Europe. This is equivalent to HRS in the US. He's a research associate at NBER and other research institutes. Michael will switch gear and talk about healthcare issues, pathway to disability, predicting health trajectory. Michael.
Well, thank you for inviting me to this interesting conference. I will be talking about disability, and the importance of disability for retirement income adequacy is, there are several reasons why it's important, but one certainly is the ability of individuals to work past what has been normal retirement age is an important factor in people being able to reach retirement income adequacy. A few extra years of work life will make up for a very substantial amount of lack of saving. But an important issue is whether people will be able to work longer, and that's closely related to their levels of physical functioning and mental functioning, that is to say, levels of disability. We could look at disabilities in several ways. The first way, and most obvious way, is in cross-section data, that is to say, what are the levels of disability that we see in data as a function of age. Look at disabilities among 65-year-olds and 75-year-olds and 85-year-olds, and that will tell us what the current level of disability is in a population, older population. The second way of looking at disability, however, is to wonder what disability will be in the future. That is, take today's 65-year-olds, what will be their level of disability when they are 85 years old? And those answers to those two things may be quite different because of improvements or, in fact, degradations in health that occur over time. So far, probably we've experienced improvements in health, but that's not necessarily the case in the future. You think of the rise in overweight and obesity, which are associated with diabetes and other illnesses. It may well be the case that we've seen in the developed economies a peak in health at older ages. We just don't know that. So I'll be addressing both of those issues, but for the importance of this conference, I think the thing to keep in mind is, will people be able to work longer? And that a key issue to that is what their health status will be. Well, to define disability, there are a number of ways of defining disability. The most common ways to measure are limitations in so-called activities of daily living, or ADLs, activities of daily living, or limitations in instrumental activities of daily living, and I'll say what those things are. The activities of daily living that are commonly measured are these that you see on the screen now: eating, dressing, bathing, toileting, getting in and out of bed, and walking. These are things that people have to do on a daily basis, some way or another, and if they are unable to do them on their own, then they will need help in doing those things. And if they're severely limited, they may not be able to do these things. So if someone has a limitation in one of those things, that's an indication of something that everybody has to do. Instrumental activities of daily living, or IADLs, are things that not everybody actually has to do for themselves, but they're things that have to be accomplished for people in order for them to carry out their lives. For example, people have to eat, somebody has to shop for groceries, telephone calls, and so on. And these things, as you can see, are kind of a combination of physical capabilities, but their mental capabilities also, as well as the desire and need to do those things for yourself. Some people, in fact, do not drive, and they never have driven, and yet they're perfectly healthy. So those IADLs have to be treated with a little bit of caution in interpreting health of a population, and I would say I will concentrate on ADL limitations, not IADL limitations. What I'm going to talk about is the measurement of disability, how it's actually measured in household surveys, in particular the US survey that I will be talking about, patterns with respect to age, trends over time in US data, and finally using panel data, that is observations on the same individuals over time, to estimate lifetime paths of disability to get at the second issue that I talked about before. The data I will use for this talk is the Health and Retirement Study. This is a large study in the US, and it's unique in the, I would say, worldwide. It is a very large panel data set where the same individuals are interviewed every 2 years. That is to say, it's longitudinal. Age 51 and above, it began in 1992 and has continued until 2012 and will continue at least until 2016. And so you can see we have, even now, 11 waves, interview waves on the same individuals, and we can see individuals progress through retirement into old age and finally, if we continue this long enough, until the entire cohort has died. And so we will have complete information on individuals' pre-retirement years advancing clear through death. The HRS has been the mothership, if you will, for a number of other surveys with similar structure around the world. There's the English longitudinal study of aging in England, the Survey of Health, Aging, and Retirement in Europe, which is a survey of now 15 to 20 European countries. There's the JSTAR, the Japanese study of aging, the Charles, the Chinese study of aging. There are surveys in Israel, in Argentina, and under development in Thailand and many other countries. The importance of this observation is that by using these surveys, which have the same structure, we can look across countries and see whether outcomes differ across countries, for example, economic preparation for retirement, and relate those outcomes to government policies. So these surveys functioning together are like a laboratory where we can give different populations different treatments, different doses of treatment, and study the outcomes. And we've done this with a number of important outcomes, in particular, for example, how well individuals or households have saved for retirement as a function of the public pension system. And it turns out that you can see fairly clearly in the data that in countries that have a high level of publicly provided pensions, households tend not to save very much on their own. In countries where there's a low level of public pension system provision, such as the US, households tend to save a lot in compensation. So I will say the things that Deborah Ralston talked about, in fact, are really complex. We could have discussions about the ability to blend private saving with public pension systems to arrive at a good level of adequacy, but that's a topic for another discussion. The domains of the HRS, I've put up some here. What's important for this talk is really health and health service use, and cognition is actually a very important issue that has now come to the fore in health and retirement type studies, because it's very clear that if people's cognitive status declines sufficiently, they will not be able to care for themselves, either with ADL limitations or IADL limitations. Family connections are also important, expectations, and HRS has much more. The HRS is also linked to administrative data, in particular Social Security records. Social Security is the US public pension system, to Medicare records, which is Medicare is the US health insurance system for those over age 65, and to the National Death Index, and in some cases to private pension system records. The measurement of ADL limitations in the HRS, which is quite similar to the measurement of ADL limitations in many, many household surveys, is you can see the exact quote here. Please tell me if you have any difficulty with these because of physical, mental, emotional, or memory problem we ask them to limit these things to something that's expected to last more than 3 months. So we don't want, for example, somebody to report a difficulty in walking because they have a broken leg that is expected to be healed. These are supposed to be more or less permanent things. We'll see in the data that in fact they're not permanent, at least not in the entire population. But that's kind of the objective. And then this is a critical, because of a health or memory problem, do you have any difficulties with these things, dressing, putting on shoes and socks? So this is the one about dressing yourself. And this is repeated for the other ones that I mentioned: eating, bathing, toileting, getting in and out of bed, and walking. As a follow-up, we ask people whether they get help if they have difficulties doing these things. We ask whether they get help with these activities. If so, who helps them and how much? And these data are very useful and valuable in understanding health provisions and helping behavior as an alternative to nursing home entry. And you can actually put a value on this so-called informal help. And we also ask about the use of assistive devices, as you can see here. Here is this slide shows the pattern of ADL limitations. And what you can see, the red bars show individuals who have one or more ADL limitations as opposed to 0. And you can see that, this is from the HRS, that among men in the age range 55 to 64, a little bit fewer than 10% have any ADL limitations. Also 90% are ADL limitation free. They can perform all of those activities of daily living without any problems. The second thing you can see is that the fraction who have ADL limitations increases rather sharply with age. At age 85 and above, more than 30% have an ADL limitation. The second thing you notice is that although people have limitations, a substantial fraction of those do not receive help. They try to accomplish things on their own. That's partly because they use equipment. People use canes and walkers and wheelchairs to help themselves. There's a substitution, in other words, between receiving help for something and using equipment. And of course, receiving help will also depend upon marital status. Is there somebody there to give help? But the basic pattern here is sharply increasing with age. Among women, more or less the same pattern. I will make a comparison between men and women in a minute, but you notice immediately that age 55 to 64, more women have an ADL limitation. It looks like there's around 13%, and men it was about 9%. And that's true throughout the age distribution. And here's the comparison. Women have more ADL limitations than men. Here's an example at age 65 to 74. 16% of women have an ADL limitation, 10% of men, and more receive help and more use assistive devices. And the reasons for this are not well understood, I have to say. We know that women live longer. These same women who have more ADL limitations than men live longer than men do on average. So what is going on here? Are women complainers? Or what is I'm not going to take a stand on that because for several reasons. I'm a married man myself. I wouldn't. Measurement of IADL limitations. So we've asked about ADL limitations, and now we're going to ask about IADL limitations. And so notice we say a physical, mental, emotional, or memory problem. So people can have these limitations for a number of reasons, and these are all important. Emotional problems actually are quite important in the older population, so we need to say something about that. Do you have difficulty with these activities? Again, we have a 3-month window here for temporary things. Because of a health or memory problem, do you have any difficulty using a map to figure out how to get around? Now this is This is one reason I don't like IAD limitations. There are plenty of cognizant people who have problems using a map. They hold it upside down so the south is at the top, and of course they're not going to go anywhere with that. Nonetheless, preparing meals, and you can see the things that are. And of course, this is, across cultures, is a difficult thing to compare. In some cultures, men would never prepare meals. In other cultures, they do, and so cross-country comparisons are difficult to make using IADLs, and that's one reason I'm not going to really talk about them. Nonetheless, here they are, and they show the difference with the prior graphs on ADL is the one in green is whether people do not drive. In some countries, that's a very important limitation on the activities of older people because of, if you live in Los Angeles, for example, which is where I live, if you're not able to drive, it's very difficult. The public transportation system is not well developed, and you're relying on people to do anything. And you can see an increasing fraction of men with IADL limitations and an increasing fraction of men who do not drive at age 85 and above. More than 30% do not drive, which makes things difficult for them. Among women, higher levels of not driving, in particular at advanced old age. Some of these women have never driven in their lives, but you can see the very sharp increases, which make things difficult for people. A comparison, men and women have about the same frequency of IADL limitations, with the exception at advanced old age, where women have more, and where women have a higher frequency of not driving at all ages. I'm going to concentrate on ADL limitations for the reasons that I've kind of outlined. I think they're really more fundamental. And also, furthermore, in discussions about transfer behavior, I should say public systems to transfer resources to people with disabilities, it's really a focus on ADL limitations, and often is a focus on people who have 2 or more limitations. That's defined in public discussions of transfer, who should get transfers for being disabled, as the group with disability, 2 or more ADL limitations, and so that's what I will focus on. Well, here is the prevalence in cross-section of ADL limitations. The top line, the blue line, shows by single years of age the fraction or the percentage of the population that has no ADL limitations. You see, this combines men and women, that at age 65, about 88% have 0 limitations, and just about 6% have 2 or more. So if you're using the definition of 2 or more ADL limitations, you would say at age 65, only 6% are disabled. This immediately tells you, according to this metric, that a substantial number of people in their late 60s are able to work. If you think people with disability, as according to this measure, are not able to work, and people who have 0 or 1 ADL limitations are able to work, that tells you a substantial fraction of the population is able to work. And indeed, in the US, as in now starting to occur in European countries, we've seen a very substantial increase in the fraction of people over the age of 65 who work. Among men, over the past 15 years, the percentage has risen from about 25% to 35% among men aged 65 to 69 who actually are working. And among women, the trend has been similar. And according to data we have on people's expectations, I expect this trend to continue. We'll see greater and greater work effort in the older population. But the good news here is that even among people in their 70s, there are a substantial number of people who have 0 ADL limitations and may be able to work. The other 2 lines show people, the fraction of people with 1 ADL limitation in the red, and the fraction of people with 2 or more in the, well, I don't know what color, avocado or whatever that is. And you see, of course, at advanced old age, a very high fraction of people are disabled according to this definition. Something like 50% among people in their 90s have 2 or more ADL limitations. An important issue, of course, is what is the trend in these limitations, which I'll return to in a minute. And that's a subject of very considerable debate. It's also the case that those with higher socioeconomic status have fewer ADL limitations. And here is a graph that shows the same thing that I just showed, but now stratified by education level. The blue line, the lowest line, is among those who lack a high school education. So in the US system, that would be people whose education level is 0 to 11 years of education. 12 years in the US system is high school graduate, so 0 to 11. And you can see that at age 65, around 79% of that group have no ADL limitations. The top line is those who have a college education, and among those, about 94% have no ADL limitations. So very substantial difference, even at age 65, in disability levels according to education level. You would find the same thing if you did that stratification by income level or by wealth level or by by cognitive status, by many measures of socioeconomic status, by type of occupation and so on. You'd find exactly the same thing. So there's a very high correlation between socioeconomic status and health, and in particular with disability. The other thing that you notice is that as in cross-section with age, this order is preserved, the ranking is preserved. At advanced old age, those who lack a high school education, that is the blue line at the bottom, have many fewer people who are not disabled. That is, many more people have an ADL limitation at advanced old age among those who with low education. So the curves more or less move in parallel throughout the life course. The counterpart of that is those with 2 or more ADL limitations, and you see exactly the same thing. At age 65, more than about 12% of those who lack a high school education have 2 or more and would be classified as disabled. And among college people, just about 3%. So a very substantial difference according to high school education. And again, over time, those rankings are preserved even at advanced old age. Well, an important issue is the time variation in prevalence of ADL limitations. Are we getting better or are we getting worse in ADL limitations? We can use the HRS data to answer this because we've been looking at cohorts over time for a long time period. And so what this graph shows is the percent with ADL limitations among those aged 65 to 69. And the top line, the blue line, is the percent with no ADL limitations, and you can see it's about 88% in 1996, and in 2010 it's also about 88%. Basically a completely flat curve, no change in ADL limitations in the HRS among those aged 65 to 69. So no improvement or no deterioration in health at that age. And the bottom lines are those with 1 or 2 ADL limitations. Those are also flat. So no time variation at that age. This is the percent with ADL limitations age 70 to 74 over the same time period. And I read this as sort of being basically flat also. Really not much time variation. 75 to 79, the same thing. But at age 80 to 84, the top line, we began in 1996 with around 68% having no ADL limitations, and that increased to about 74% by 2004. So somewhat of an increase in the percent who have no limitations over this time period. That indicates somewhat of an increasing health of the population over time in this age band. And correspondingly, and maybe more importantly, among those who have 2 or more ADL limitations, in 1996 this was about 20%, and by the end of the time period this had decreased to around 15 or 16%. So percentage points, about 5% decrease in terms of percents, about a 25% decrease in the fraction of the population with 2 or more ADL limitations in this age band. Well, that's quite encouraging. ADL limitations are associated, as I'm sure Libby Mitchell will demonstrate, with nursing home entry and other expenditures and so on. So this is kind of encouraging and is an indication of possible increases in health in the older population. Here that summarizes exactly what I said before, so I won't repeat that. 85 and above, sort of the same pattern, the same good news, but there's a time lag in the increase, more or less flat between 1996 up to 2000 and the top, 2002 in the top line, and then a fairly substantial increase since 2002 in those age 85 and above who have no ADL limitations. You can see going from 50% up to about 55%. And a similar drop in those who have 2 or more ADL limitations from around 35% to 30%, so a 5 percentage point decline in the fraction of the population that has 2 or more ADL limitations. Well, if you kind of compare these two graphs, what you see here is the increase began in 1998 and persisted through 2004 when these people were 80 to 84, and now we move up here, we see that increase began in 2002 and persisted up to 2008. So it's like there's a cohort difference that began in 2000 at age 80 to 84 and now is moving into the older age group. It's kind of like a wave moving through the ages that we can see right here in these graphs. So that's kind of interesting and worthy of further research. Is this a cohort effect or is it a change in transition rates? That summarizes what I just said. So here's kind of a summary of that. The reduction in ADL limitations over time in those age bands could be due to healthier people reaching age 80, and therefore you have fewer limitations, or it could be a reduced transition rate into ADL limitations at those age bands. And it kind of looks like it's a reduced transition rate into limitations, because we did not see this showing up, if you remember, at these younger ages, where we should have seen this showing up if it were kind of a permanent cohort effect. So it's probably in transitions that change in transition rates, which is certainly interesting and worthy of more research. So that's showing you the pattern by age and limitations and the pattern over time. And now I want to turn to transitions in ADL limitations, what we can do with the panel data. So the thought experiment here, what we do, we see the status of individuals in a particular wave of the HRS, say in the year 2000, and we see the status of those same individuals in 2002, and we want to see how many people went from having no ADLs to 1 ADL to 2 ADLs, and how many people in fact made kind of the reverse transitions from having 1 ADL down to 0, or from 1 ADL up to 2, and also conditional on initial ADL situation, how many people died. So we're looking at changes between 2 waves, and I will use all these transitions that we see in the HRS, as you can see here, 1992 to 94, 94 to 96. So I will ignore that little bit of change in transition rates, possible change in transition rates at age 80 to 84 and 85 and above that we saw in the time trends. I'm going to ignore that for this and just look at what happens from the transitions. So to give you an idea, when we stack all these data, here's what we see in terms of N. So HRS is a huge data set, especially when you use all these waves. We have 144,000 transitions. That's in the lower right-hand corner there. These are the ends. And for example, among those people who had no ADL limitations in a particular wave, there were 120,000 such people, and that is in the right-hand column. And among those people, 104,000 in the next following wave still had no ADL limitations, and 7,000 now had one ADL limitation, and 4,000 had two, and 5,000 of those people had died. So that's the kind of basic data that we see in the HRS. And among those people who had one ADL limitation in a baseline wave, there were 12,000 of those people. You can see that 5,000 transited down to zero. So these ADL limitations are not permanent, at least as reported by individuals. Some people who have ADL limitations in the next wave report themselves as not having any. The time frame, as you recall, was 3 months when we asked about how long this is expected to persist. But there are some limitations that people have that persist for more than 3 months, but less than 2 years, obviously. There's also reporting error, it has to be admitted, where on a particular day somebody doesn't feel good. They say, oh, I have trouble getting out of bed. Maybe that person went hiking the day before, for example. That could happen. One thing so those are the ends, and that's what I'm going to be showing you. It's more useful to look at transition rates, however. So now I'm showing you exactly the same thing, but where everything is normalized to show you transition rates. So for example, among those with zero ADL limitations in a particular wave, 87% had zero limitations in the following wave, 6% had one, and 4% had two, and 4% had died. And one thing you notice is that there's a tendency to have, for people with zero, to remain at zero, 87%, so most people remained at zero. Among those with two or more, the transition rates, 47% had two or more in the following wave, but even some of those with two or more transited down to zero or one. A total of about 25% had reduced their number of limitations. The other thing you notice is that ADL limitations are highly associated with death. Those with two or more, in 2 years, 28% of those died in the 2-year time period. So if somebody has two or more ADL limitations, that's highly predictive of mortality. Whereas those with zero, only 4% have died. Now, this is not corrected for age, and we have already seen that age is highly correlated with ADL limitations, so you want to do something about that. Which this slide does. So this slide shows the transition rates among those who have zero ADL limitations in a wave to their status in the following wave, but now, this is the same thing I showed you before, but now stratified by initial age. So you see among those aged 65 to 69, 90% transited to zero and just 3% died, but among those 90 and above who had zero limitations in the baseline wave, only 43% continued to have zero and 25% had died. So there's an important age distinction here, but ADL limitations controlling for age also matter. And so what I'm going to do now is show you some graphs of exactly this table. And let's just concentrate on two things. Let's concentrate on the top line, which is the transition rate into zero ADL limitations, and the other blue line, which is the fraction who died. So these are transition rates among those people aged 65 to 69 in the left side who had zero limitations in wave T. And so 90% of those aged 65 to 69 transited back into zero. But among those who are 90 and above, just 42% transited into zero. This is the table I showed you before. But now I'm going to show you this for transitions from two or more ADL limitations. And you see that people who have two or more ADL limitations, some of them transit back into zero, but the fraction an important thing here, the fraction of those who die increases very sharply with age. By the time people are age 90 and above, about 55% of those will have died 2 years later, so among those with 2 or more ADL limitations. Well, the last thing I do will then forecast disability rates from these transition rates. The thought experiment is we begin with people at age 65 who have ADL limitations. We use these wave-to-wave transition rates and simulate out the fraction who will have ADL limitations. And so this answers the question, if patterns of transitions remain the same, what will things look like for people who are now age 65? And here's what they look like. The first thing is survivorship. We predict survivorship very closely to life tables. As you can see here, the blue line is predicted fractional life, and the red line is the actual life table. And then here is really what we want to look at, the predicted ADL limitations and cumulative deaths among people age 65 from these transitions. And you can see that for the top left, the blue line is the fractional with 0 limitations, and just as we saw in cross-section, very sharply declining fraction of people with 0 limitations. And in fact, I'm not showing this, this blue line very closely tracks the cross-section, again indicating we have quite a bit of stability in ADL limitations over time because the transition rates track the cross-section very, very closely. Not much evidence then, not substantial evidence for any changes in overall health. This shows predicted survivorship according to initial ADL limitations. The top line is among those who have 0 initial ADL limitations, and so you can see that even by age 85, around 45% of those who had no limitations initially are still alive. Among those who had 2 or more, only around 25% are still alive. So ADL limitations are very important predictors of survivorship. And I'm going to skip these. I think everything I wanted to say I've said. So conclusions, firstly, disability is highly predictive of mortality, holding constant. I didn't hold constant a lot of things here that I could have, but had I, a disability is still highly predictive of mortality. Here are some comparisons. 53% to age 75 compared to 78% with 0. Sharply increasing rates with age. In the US data, some possible improvements with age at advanced old age. At younger ages, no real evidence of that. As for improvements in health, helping out the US healthcare system, really not much evidence, at least for these age bands, that is happening. And at younger age bands, there actually is some evidence in the HRS of worsening health, not improving health. So I think that from that perspective, that is not good. And then the final thing I will say is that to study these processes, we need long-running panel surveys of the HRS type. We just cannot study these things in cross-section data or in any other type of data. I've just begun to show you a few things you can do, but the number of things you can do is basically limitless. Well, thank you for your attention.
I have a measurement question about the ADLs. Is that HRS is self-reported, and I was just wondering whether it trails closely to if we use another measure for ADL limitations like the modified Barthel index. And the reason I ask this, it's a policy question, because in Singapore, there's the Elder Shield insurance for long-term care. So people get insurance, and then if they can prove that they have ADL failure, it's 3 ADL failures, then they get a cash payout for long-term care. So do you think that the HRS data that you're working with, the panel data, what you show here trails very closely if we were to use the modified Barthel index?
It's not at all obvious how you would implement some other scheme. I mean, you could require doctor visits of everybody, or nurse visits, to kind of get an independent assessment. Recall that some of the disabilities can be like mental health problems, they could be depression, so on and so on. Very difficult to assess these things I will say that the relationship between ADL limitations as self-reported and among qualifications of people for disability insurance through the Social Security Disability Program is quite high. And that qualification does depend upon a medical examination. So there is independent evidence that ADL limitations, well, you saw the predicted power for mortality, and there's kind of no disguising that. But there are undoubtedly classification errors. We've seen a substantial number of people have 2 or more ADL limitations. These are supposed to be permanent things, but then they recover, about 25% recover. So there is classification error. I guess the problem is, in a cost-effective manner, what else could you use? A second issue that maybe you're thinking about is kind of moral hazard. If indeed programs become dependent upon self-reported ADL limitations, then you might have to expect human behavior to, as we say, rear its ugly head and interfere with this. So I guess my short answer is that they have predicted power, and we don't really seem to have anything that's really verified.
I was wondering, I was very surprised at the lack of time trend in the ADLs, and I was wondering whether, if you looked at it in another way, which is a percentage of your life spent in, at the end of your life spent in an ADL, a 2+ ADL group, whether that's the more relevant. There's another way to measure what it means to have ADL, because you've got the confounding effect of life expectancy versus ADL. So I just wondered if you looked at that particular.
Well, you can see that among those, that there must have been an increase in healthy life expectancy, because life expectancy itself has increased, ADL limitations did not increase, even at younger ages, and at older ages, it actually limitations decreased a little bit. So there must be an increase in that. I haven't looked at that specifically. I had heard a quite interesting talk 2 months ago by David Cutler, who looked at exactly this issue, and there, for the first time, I saw evidence that I think is credible about an increase in healthy life expectancy, and more to the point, maybe a little bit of shrinking of the total number of years spent in disability. So that's kind of a different thing. If ADL limitation free increases by 5 years, life expectancy increases by 5 years, both healthy life expectancies increase in life, but the fraction, the years spent in ADL limitations has not changed. The fraction of life has spent in limitation has decreased. So he's looking at that little bit at the end, and actually saw maybe possibly evidence of a shrinking of that. So that was quite encouraging. Again, what the long-term trend is, that needs to be repeated, because it's a very important issue, as we know. Important implications for nursing home use and healthcare costs and so on. But I think it needs to be repeated, and we also need to get some understand what's going to happen when the, if you will, the obese generation reaches these ages.
The transition question is how many percentage go from 0 ADL to death, which you would think is a good death, which a lot of people want. Is that a death where you have 0 ADLs and you die? I mean, when you ask people what's the death you want, that's
Please don't put such words.
Survivorship for college-educated people. And what is the contributing factor?
Well, there are two, broadly speaking, at the ends of the thinking about this. The first is that if you get educated, that in and of itself will increase life expectancy. There's something about the education process that increases your human health capital. So if I take a person with a high school education and force that person to go to college, that person will live longer. That's one extreme view. The other view is that it's all selection, that healthier people who are intrinsic, they start off life with better health, better access to resources, and so on. Those are the people who get high education, and therefore those people live longer. They would have lived as long had they gotten a high school education rather than college education. And it partly depends on the discipline you come from about what your view is on that. My view is that it's mostly selection, that it is not education per se that does that. That these people would have lived more or less the same had they received less education. But it's very hard to distinguish that in data because you don't have the counterfactual experiments.